Good afternoon, everyone. Thank you for joining this session, and thank you for staying on for the afternoon session. I hope you've enjoyed the conference so far. This afternoon, I'll be co-moderating this afternoon together with Helen Nabuera. I just introduced myself briefly. My name is Dr. Charles Arme. I'm a senior clinical lecturer here at the School of Tropical Medicine, and I'll be co-hosting this session with...
Yes, so my name is Helen Nabuera. I'm a pediatrician based here at the Liverpool School of Tropical Medicine.
Yeah, so I'll just tell you the layout of we'll just run through the program for the afternoon. So we start off with 2 breakout sessions. So the first session will have 3 oral presentations hosted in one of the breakout rooms. So to join this presentation, after we finish the introduction, you have to click on the specific link in the app. The other parallel session running at the same time from 1400 to 1450 will be the NIHR Global Maternal Health Group panel, where we will have 2 professors, Professor Lavender and Professor Dili Anumba. So if you're in that session, I'll tell you more about our complete panel. Then
We then have a series of workshops where we'll have more kind of like in-depth discussions about implementation research, just tying in what we did, we've discussed this morning. So the first one will be on creating new healthcare facilities. That will be with Professor Imelda Bates, Dr. Kathy Burgoyne, and Dr. Helen Allott. And then the second one will be achieving respectful healthcare, again with Dr. Annie Potela, Professor Salome Maswime, and Professor Tina Lavender. And the third one will be about achieving positive childbirth experiences, again with Professor Sally Theobald, Professor Indy Kaur, and Professor Andrew Weeks. So you're welcome to join any of those sessions by clicking on the appropriate links.
Yes, so after the first group of parallel sessions between 1400 and 1450, we will remind you of the instructions again, how to join whichever of the 3 breakout rooms that you like. We will end the day by streaming 4 very interesting Pechakucha style presentations. They're really interesting, and for this, at the end of this streaming these 4 excellent presentations, we will have a brief discussion about them. There are no questions to field. You can put text. The presenters can reply you, but we're going to do a bit of X factor here, where the audience has to vote. Polling will be open just for about 10 minutes, and then the best Pechakucha style presentation gets a prize from GLOW 2020 organizing committee. So good. Now I think we have all our instructions. So we're going to break out now into the rooms to run the sessions. So you can click the link to go into the oral presentations on implementation science now, or you remain with us on this channel for the NIHR Global Health Groups. Now we have 3 members of the panel for this workshop, and one of them is joining us online. I cannot see Dili online. Can you get him online, or does he only come on when he speaks? Yes. Hello, Professor Anumba.
Hello.
Can you hear us?
Yes, I've been online, yes.
Good. Thank you. No, I just wanted to see you to confirm that you are with us. So I'm going to introduce members of the team. So sitting with me here in Liverpool is Professor Dame Tina Lavender. So she says she just waved. So she's a professor of global maternal health and has extensive experience conducting research in low-resource settings. She's also here with a member of her team, Tracy Mills, who's a senior lecturer as well in global maternal health. Sitting in Sheffield is Professor Dili Anumba. He's a professor of obstetrics and gynecology and a senior academic and he's also leading one of the NIHR global research centers. So I will, the way it will run is I will hand over to Professor Demtina Lavender, who will make a presentation combined with Tracy, and they show a video, and then they pass on the torch to Dilly, who will take over, complete the session, and then we can field some question and answer. So I encourage you to put in questions in the question and answer box for this session on the app, not in the chat. If you put them in the question and answer section, then we can pick them up and field to the team. So thank you very much, Professor, and you can make your presentation. Thank you.
Thank you very much. I'm delighted to give this talk on behalf of the team. So thank you for joining this session with us. I know that not all of you will be aware of what the NIHR Global Health Groups are. So I'm going to start off for the first few minutes just giving you a few slides on what it's all about. So just as a way of a bit of history, the National Institute for Health Research, NIHR, was established in 2006 to improve the health and wealth of the nation through research. And in 2015, the NIHR Global Health Research Group portfolio was established to support applied health research for the direct and primary benefit of people in low and middle income countries. And as part of the commitment by the NIHR was to produce these awards made available for research units and research groups. And these provide funding to researchers within universities and research institutes in low middle income countries and the UK who wish to establish new programmes of applied health research. We're currently in the third round, and there are various levels of commitment. For units, it's maximum of 5 years and £7 million is available. And for groups, it's maximum of 4 years with £3 million available. And the awards support delivery of research that will improve health outcomes for people in the low middle income countries and to strengthen the research capability in resource poor settings. So I'm going to focus on the research groups, and that's what myself, Tracy and Dilly will talk to you about today. But just to home in a little bit on their purpose is to address locally identified challenges in low middle income countries through equitable research partnerships between the researchers and institutions in the UK and ODA countries, to generate scientific evidence that can improve health outcomes for people in low resource settings through improving practice and informing policy, and to strengthen research and research management capacity and capability to support future sustainability of research in partner countries. So global health research groups are either new to delivering applied health research globally, or they wish to expand an existing partnership. And groups address unmet global health needs through equitable research partnerships. And the equitability is a really important underpinning concept of these groups. You must have joint UK and LMIC applicants, clear plans to strengthen that capacity, and must be able to support future sustainability in partner countries. To date, there are 3 research groups which are directly related to maternal and newborn health, although there are many others that have some relevance to them too. And you can find all of these on the NIHR website. But the 3 that are particularly pertinent to us today are these 3 listed here. So there's a group in Edinburgh, the Diplomat Collaboration, looking at preterm birth and stillbirth. And you can see Jane Norman in the picture there, who was the lead director. There's our own group, which I'll tell you a little bit more about. And then there's Dilly's group, which is PRIME, which is preterm birth prevention and management. So I'll just move on to our group and give you a little bit more detail. So this is our group, our NIHR group on stillbirth prevention and management in sub-Saharan Africa. And you can see most of the team here. We work across 6 different countries, which is Kenya, Malawi, Tanzania, Uganda, Zambia, and Zimbabwe. And a core principle related to our research group is that we have active community engagement and involvement. And there's been an awful lot of information already in the GLOW conference about co-production and engagement of women and families. And I would say that within our group, they have really informed everything that we've done from the start to the dissemination. So just to give you a bit of a background of why we're doing this, we know that globally 2.6 million babies die just before or during birth each year, and that the majority of these are in low and middle income countries. Stillbirth is a tragedy for women and families. There's long-lasting grief for their baby, increased risk of poor psychological health, and poor basic care and support. And as been mentioned before, I think it was in Kate's talk, in sub-Saharan Africa, over half of stillbirths happen during labour in association with preventable complications. So this means that the majority of those babies that die, we could actually save with the right efforts. So this map, many of you will have seen it from the Lancet series, which if you haven't seen the Lancet series, please do go and have a look. It's excellent. But this shows you the countries with the highest stillbirth rates and the highest stillbirth numbers. And I just want you to look at this for a second and just keep this in your mind when I show you the next slide. So from this slide, you can see that the darkest colours and the biggest circles are the highest rates and the highest numbers. Okay, so just capture that image in your mind. And also from the Lancet, this is a map showing the sites of the research into the impact of stillbirth. So you can see that there's a huge mismatch between where the biggest need is and where the research is being carried out. So these are the countries that we're involved with, and you can see on these flags the actual stillbirth rates. And I've also put up our own rates just to show in the UK, just to show the comparison. This is really testing your knowledge of flags here, but if you go along the top, it's Kenya, Tanzania, Malawi, Uganda, Zambia and Zimbabwe. And you can see that they're all around about the 20 per 1,000 births, whereas for us it is only 2. And you can see here that stillbirths really do count, and this is one of the important things that we have to realise, the impact on the women. And this is a quote from a South African artist. I'll let you read the quote for yourself. And there's many, many more of these out there. Women's stories are very, very powerful. But as a consequence of the stillbirth, 4.2 million women have depression as a result. So this is huge. So the aims of our group is to look at the main causes of stillbirth so we can apply interventions to prevent it happening, to explore why women do not receive appropriate labour care in a timely fashion, and to explore the best way to support women and families after the death of their baby. And to do this, we've used various approaches, and I don't really have any time to go into these in any detail today, but please do get in touch if you want to know more information. But this schema just shows you that it's a mixed methods approach that we used with retrospective cohort studies, mixed qualitative work, standalone qualitative work, clinical audit, feasibility studies, and we're at the point now that we're going to move on to some definitive trials. I thought what would be more interesting to you is to find out what we've achieved so far, and it is still ongoing. So I've taken each country and just picked out some of the highlights. So in Zimbabwe, we found that non-attendance at antenatal clinic and previous stillbirth were highly associated with recurrent stillbirth. And the impact of that was we introduced a clinic, the Tembani Clinic, which means with hope. And this is for women who've had a previous stillbirth. And in Tanzania and Zambia, we found that barriers to timely transfer, unexplained stillbirth, and communication around stillbirth were three really problematic areas. The impact of this is that we've introduced individual birth preparedness plans to develop underpinned by a new model, a women's health empowerment model. We're exploring the use of non-invasive investigations, and we're developing and testing a communication training intervention. Also in Tanzania, we found that partographs, which are the labour monitoring charts, if anybody doesn't know, were not completed or completed incorrectly. So we've worked with WHO in developing and testing their new labour care guide to make sure contextual relevance. In Malawi, we found that maternal observations were not being completed, and one of the areas was the fetal heart rate was not being listened to prior to caesarean section. The impact of this has been that guidelines have been implemented and practice has changed, and now there's been an increase in observations being carried out, including the fetal heart being listened to. And in Kenya and Uganda, we found that bereavement care was highly inadequate, and healthcare providers were not adequately trained or prepared in order to deliver bad news. The impact of this has been a bereavement intervention which we have developed, and it's currently being tested. And in some of the sites, they now have a bereavement counsellor who's been assigned. There's dedicated rooms and a place to rest the baby, and there's a network of peer supporters. And finally, before I pass to Tracy, just a few of the additional impacts that we've had. Stillbirth has been tabled as a priority by the Ministry of Health in Zambia, following presentations by the Community Engagement and Involvement team. There's been capacity of individuals developed. These are the researchers, some who had never done research before. We've developed a number of educational board games that you can see here for in-service training and undergraduate teaching. And we've had active input of finding the international bereavement guidelines. So I'm going to end it there, and then I'm going to hand over to Tracy, who's going to talk specifically about one of the work streams on bereavement care. Thank you.
Okay, thank you very much, Tina. It's great to be here. The Liverpool School of Tropical Medicine will be my new home from Monday, so I'm very much looking forward to starting. So as Tina said, I'm just going to talk to you about our research journey as a group. So I'm speaking on behalf of all the people who've been involved in this work stream, too many to name. So we've been doing quite a lot of work surrounding trying to improve the care and support that parents receive after their baby dies. And I think we as a group feel this is extremely important in improving care related to stillbirth, and we need to give this as much attention as any other aspect of this research. So again, I probably don't need to convince this audience, but Tina very clearly stated the importance of stillbirth and neonatal death for parents. We know that the death of a baby is amongst the most traumatic life experiences that anyone can come into contact with throughout their life. It has huge and long-lasting psychological and emotional effects on parents, which permeate more widely through society. So we know that there are poor health outcomes in terms of psychological and physical health. There's also the issues caused by stigma and abandonment within communities, and these can increase the risk of social problems like family breakdown. We've got increased health costs for governments and reduced economic productivity resulting from this terrible tragedy for parents. The good news is, though, that with appropriate care, people can move on effectively with the rest of their lives, but it's important that they do get proper care. So it's very important that parents whose baby dies receive appropriate support at that time. And we know that the hours and days immediately after the birth are particularly important and a key period for support to be initiated. And now a lot of our work globally is focused around encouraging women to give birth in facilities, so therefore health workers have a very important role at this time when a baby dies, because those births will include some stillbirths and neonatal deaths. There has been some research done globally looking at parents' experiences of support in this period, and what we know is that even in high resource settings with good levels of resource and adequate numbers of health workers, parents' experiences are not always positive. But there's very much less known about the response of facilities and systems in low and middle income countries. So across the LAMRA network, our first challenge was to explore this issue in a little bit more detail and find out about parents and health workers' experience. So we conducted a qualitative phenomenological study. So that involved conducting some one-to-one interviews. So we interviewed 75 women, 59 male partners, and that was within a year of their stillbirth, because we wanted the data we got to represent current care. We also interviewed 53 health workers, and these experiences took place in 5 facilities in urban and rural areas of Uganda and Kenya. So what did we find? Well, not too many surprises, but some really interesting data. So the overwhelming response of the women and their partners was profound shock and distress at the loss of their baby. There were actually some positive experiences. I was listening to the previous presentation and people were saying it was important to point out when care was positive, and the parents acknowledged the efforts that some health workers were making under very difficult circumstances to give them good experiences and support, but there were lots of challenges. Parents reported feeling what they called left in the dark because of too little information after the death of their baby, and some episodes of quite insensitive and distressing communication from health workers. There were also some environmental barriers to effective care. So we've heard repeatedly that facilities lacked sufficient numbers of staff to interact with the women as much as they would have liked to. There was very little privacy and separation from women with live babies, and that was a source of distress to the parents. And some of the facilities also had some policies and processes which actually were quite unhelpful. So particular examples were restrictions on companion support. So partners would turn up once they were informed that their partner had had a stillbirth and then weren't able to access her because it wasn't visiting hours. And there were some issues around handling of the baby's body, burials and funerals, which the parents found very distressing. Our health workers also had some quite negative experiences. They told us a lot about how little education and preparation they'd had for this part of their role, which they found particularly challenging. And there were a lack of role models to sort of give health workers some good role modelling about how things could be done well in practice. There was also a lack of institutional support for bereavement care as an important part of the health worker's role, and an increasing sense of individual blame surrounding some poor outcomes, which made health workers very fearful in looking after these parents and communicating with them. So this exploratory research has allowed us to think about developing some interventions to actually improve care. And we've very much drawn on our community engagement and our stakeholder groups that Tina mentioned in the previous part of this presentation to help us do that. So we've developed some interventions that we're now in the process of the early stages of evaluation, so we've got some feasibility work going on. So the feasibility study that we're conducting at the moment is testing a multi-component intervention which targets some of the issues that we identified in our exploratory study. So to improve care in facilities, we are developing networks of bereavement care champions. So these are health workers who work across maternity facilities in the different areas of the facility, are interested in this area of care and are raising awareness of the importance of this issue with fellow staff, and also developing some strategies for change. And it's all very led within the local facility, so they understand their context and what's possible within their facility. We were also developing telephone peer support to improve women's support after their discharge from hospital. We found in our exploratory study that women were feeling quite alone in this period. So we've trained lay peer supporters, so they're women who've had previous experience of a stillbirth or death of a baby, and they're providing support on the phone. So the design for these studies is a pre and post mixed methods study over 12 months. So we started in August 2019. We're recruiting 30 women per site to the intervention and comparing those women with a group of women who were cared for in the sites before the intervention was introduced. The study's being conducted in urban facilities in Kenya and Uganda, and the outcomes for this part of the study are very much around feasibility. So will the women agree to take part in the studies? Can we keep them till the end? How do they find the intervention? And we're looking also at the process of implementing the intervention and whether, you know, we might need to make some changes. So we conducted our training in January 2020, and that was a really brilliant experience, I think, for all of us, going to Kenya and Uganda and doing the training, meeting our champions and our peer supporters. So the training involved some elements of behaviour change theory, some work around listening and communication skills, and very importantly, for both these groups, some work around self-care and looking after themselves, dealing with this very vulnerable group of women who've got quite a lot of emotional needs. We have been faced with some issues related to COVID, like everybody else, but we're just in the process now of getting our recruitment restarted and completing this feasibility work. So unfortunately, I can't give you any results from the feasibility studies because we've not quite finished them. Hopefully we will do by Christmas. But the research, as Tina did mention before, has already started to make some impacts in our sites. So we've definitely increased awareness of parents' needs across all our sites. It's being talked about a lot more. There have been some changes to care provision. So some of the hospitals are now identifying separate areas and private spaces for these families. And staff across our Lavender network are asking for more support and education surrounding how to care for bereaved parents, which is brilliant. Working with our networks of stakeholders and our community engagement groups, we've been able to confirm a lot of commonality in our findings across the whole network in East Africa, which is great. And we've also been able to expand this work to Asia. So we had a small grant from the Global Challenges Research Fund to allow us to do some exploratory work in Pakistan, which is imminently going to start. So hopefully some of this work will be transferable across lower middle income countries. And we've got a larger scale evaluation of the intervention plan for 2021, which will be brilliant. So just by way of summary, so for our group, I think there's been a lot of learning that's gone on in our research journey so far. We've certainly discovered that history of stillbirth, poor antenatal care and labour complications increase the risk. Unexplained stillbirths are still quite an important issue, so we need to know more about this. Parents in the settings we're working in Africa go through, they describe their experiences in very similar ways to the evidence that we've got across the globe. So it doesn't seem that because stillbirths are more common in these areas, parents experience any less trauma. The care offered at facilities presently is not adequate and doesn't meet the needs of parents, and we do need to do things working with the clinicians in those facilities to improve things. And I think we're going to be busy for quite a long time because there's obviously a need for much more research and development of context-specific interventions. I think one of the biggest learnings, certainly for me, through being involved in this programme, is that you really need to do good quality exploratory work in the settings that you're going to implement interventions in order to make those interventions fit for purpose, really. So I've just got our little film, which I'm hoping, not quite sure how will that, oh, will I be able to start it like that? Yeah, so this is a film that we made
by the National Institute of Health Research to develop a research group on the prevention and management of stillbirth in sub-Saharan Africa. And this is a collaboration with the Lagina Africa Midwives Research Network, which is a network of midwives across 6 different countries.
So as you may be aware, there are approximately 2.6 million stillborn births annually. 98% of those are in low and middle income countries, and 60% are in sub-Saharan Africa and in Southeast Asia.
8 to 10% of our deliveries usually end up with a stillbirth.
Like in my country, it's about 22 per thousand, which is quite high.
I would say this is a very valuable project in the sense that it brings out the cases that we have on the ground.
So many people have, many research groups around the world have examined stillbirth to see why it happens, what's the pathology, what's the medical problems with it. Whereas this is slightly different in that this is looking from the other side. It's looking from the woman's perspective as the effect it has on them. It's looking from the midwives and the doctors working at the coalface, working in really hard situations in Africa.
What I find particularly interesting about this project is that it brings together what we know are key steps, not only in terms of problems, but solutions from both the woman's perspective, the provider's perspective, and other key stakeholders' perspective.
Health is more about just finding out the origin and the underlying causes of the stillbirth. Clearly that's important, but it's also very important that we know how stillbirths affect women, some of the underlying social reasons why they occur.
A lot of the traditions and beliefs make it a challenge for women to grieve, so we're actually looking at how can we implement interventions to make that possible in a way that's acceptable to the woman, the partners, and obviously the wider communities as well.
We need to have a special program how to handle them, how to make sure that they are going to be mentally, socially, physically fit.
We expect to have a change in the near future probably to see that the number of stillbirths reduce, and as a result of having this project going on.
So on behalf of our Global Health Group, I'd like to say thank you very much for listening. Please put any questions in the appropriate place and we'll be happy to answer them after the session. Thank you.
Thank you, Tracy. So we're just going to do a quick turnaround. There are loads of questions, but we'll keep them till the end just to manage the time. So can I have Professor Numba make his presentation with his group?
Right. Thank you very much, Charles. I would like to echo Professor Lavender's thoughts in thanking the organizers for inviting us to present the role. Could we have the first slide, please? I can't see the slide. Yeah, thank you. Inviting us to present the role of the NIHR research groups in maternal and newborn health focusing on stillbirths and preterm births in low middle income settings. The theme respectful care is very apt and timely in global health, and I intend to present a limited perspective of current work by the NIHR Research Group on preterm birth prevention and management, perhaps focusing mainly on exemplifying respectful care and respectful research. Could we move to the second slide, please? Now, that's the third. So I'll provide a quick overview of prime work strands and then follow that up with a few examples of our experience with women and service users and givers around respectful care and dignified care. I'll then go on to speak briefly about respectful care in relation to our physiology and pathology studies of the human placenta and vaginal swabs for purposes of understanding infection and inflammation associated preterm birth. And then I'll touch on our experiences whilst evaluating the health systems pertaining to malaria and pregnancy care in Western Nigeria. I'll mention very briefly our current work looking at the practicalities of kangaroo mother care facilities, skin to skin in the partner countries of Bangladesh and South Africa, and also from Sheffield. And we'll then present two short recorded videos sharing emerging data in relation to respectful care from our sexual and reproductive health work in rural Gauteng provinces of South Africa, and also the experiences of mums of antenatal care services, particularly in relation to preterm birth from our work in rural Bangladesh. Next slide, please. So the Prime Partnership comprised 3 countries, initially from inception on the 1st of April, 2018. So the preterm birth group is slightly younger, well, by 6 to 8 months or so, I can't remember, than the stillbirth group, but has now expanded with additional funding to include new collaborator sites with new programs of work in Nigeria and the Karnataka province in India at Belagavi and Bagalkot. So that's just a snapshot of the centers and the cities where Prime does its work currently. Next slide, please. So why are we interested in a global health research group on preterm birth? We know the statistics that 50 million babies are born preterm globally annually, of which more than 1 million die also. And even survivors are often being left with a range of disabilities, some of which can be quite profound with lifelong sequelae. And the incidence of preterm birth does vary worldwide, with a preponderance both in numbers and prevalence rates in LMIC settings, some of which have rates that exceed 15%, compared to high-income countries like the United Kingdom, with a current prevalence rate of around about 7.8%. So the Prime Research Group seeks to explore a range of research questions to contribute to tackling preterm birth issues in LMIC settings, issues such as better ways to prevent preterm birth, better ways of identifying associated infections and subclinical infections, some of them are, which are highly prevalent in LMIC settings, indeed more so in LMIC settings than in high-income settings. To prevent or mitigate them, we prioritize training and capacity development across the partnership, and the optimal delivery if a baby is born too soon of skin-to-skin care, some of the other interventions that ensure that babies can survive with a better quality of life. We also focus quite significantly on the best way to maximize the use of limited resources in these settings by prioritizing the most needed research, as one of my next slides will show. Next slide, please. In terms of implementing respectful care, which is what I'm going to focus on, we do prioritize research from the perspective of the rights of women and of empowering underprivileged and vulnerable women groups. So most of our work is in rural communities and slum areas where the least privileged reside. do forgive the basics, but we ensure that all participation in research is consensual, and recruitment of human samples is preceded by fully informed consent in all of our settings. We also try to maximize racial inclusivity by garnering and also attempt to garner and compare and contrast evidence from the different locations and contexts that could therefore enable scale-up and wider representation and implementation across a wider group of contextual areas. We do have a truly multidisciplinary team of clinicians and scientists, both laboratory scientists and social scientists, able to bring different but complementary perspectives to our engagement with and involvement of community, the public, and the patients in our research. Next slide, please. So how do we undertake the work? Part of the problem, of course, is that preterm birth is a massive problem with multifactorial etiologies. And there are so many challenges of preterm birth care in LMIC settings that what we've tried to do is to have an overarching approach to investigating preterm birth that starts out with, first of all, identifying the most important research questions, then going on to identify the evidence gaps relating to low-middle income country settings by relevant and appropriate literature reviews. And then secondly, engaging stakeholders in prioritizing the research needed so that the families and women themselves, healthcare workers and policy planners have a say in what they consider to be the most relevant in their own contexts. And then we go on to conduct the research with the aim of developing practice guidelines and guidance regarding the best approaches to deliver the best care. We also look at what the most effective interventions are with a view to achieving subsequent advocacy and scale up. So in terms of where we are, we are just moving into, we're in our third year now. And from this slide, essentially what we are going to be doing, we are at the moment developing guidelines and developing tools that can then be implemented within the fourth year, which is focusing on co-development of interventions that enable for an advocacy. Next slide, please. So we have done a lot of research prioritization during extensive meetings with stakeholders in South Africa, Bangladesh, and Nigeria subsequently. And these engagements have led to the emergence of a number of needed studies. All our stakeholders identified adolescent pregnancy as a key problem and therefore a proxy of the adverse social determinants of preterm birth in various contexts. And this was something we found both in Bangladesh as well as in South Africa, and indeed in Nigeria as well. This led to our work on adolescent sexual reproductive health in South Africa, and work on adolescent antenatal care in Bangladesh, and recently with the acquisition of additional funding, work that is about to start on adolescent nutrition in rural South India. Time limitations preclude a full narrative of the prime work strands as shown on this slide, but the next slides will touch on respectful care and respectful research in the conduct of our placental and vaginal swab studies and the implementation science studies exploring malaria and pregnancy care in Nigeria, all of which involve direct engagement with communities, women and their families, as well as policy planners and local government authorities. Next slide, please. Next slide, please. Just keep clicking because I think I've spoken about this. Yes. And the next slide. Thank you, sir. So our basic science studies to determine the viral causations and associations of preterm birth in LMIC settings is really aimed to inform maternal antenatal screening or prenatal screening or pre-pregnancy screening, and to inform interventions during antenatal care and we undertake this work employing a range of techniques as shown on this slide, some of which are quite molecular biology based. But I really bring up this slide essentially just so we appreciate the relevance of respectful care, both in the terms of the conduct of research in the basic sciences, but also in terms of how that can be perceived by the women who we need to recruit from. Engaging with mothers, we found that engaging with mothers to recruit our samples has provided us real insight regarding the perceptions of women about research on placentas, for example. We noticed differences in contexts, whereby whilst placental disposal is routine in some country contexts, in some partner countries, women would prefer to take their placentas home. This does therefore pose a little challenge with regards to mounting placental pathophysiology studies in those contexts. And we've therefore had to develop approaches to tissue harvesting and processing that respectfully treat placentas so that they can be returned to parents in a state that still allows for respectful disposal at a time of their choosing. So even in basic science research and the conduct of it, it's possible to incorporate the views of women respectfully to ensure that they get the best satisfaction from engaging with some of these studies. We'll now illustrate respectful care findings from a number of our implementation and social science studies in Nigeria, Bangladesh, and South Africa. Next slide, please. So we recently concluded a qualitative and mixed methods research study investigating intermittent preventive treatment of malaria in pregnancy in southwestern Nigeria. As we will all know, malaria is the most important infective cause of preterm birth, low birth weight, stillbirth, and fetal maternal illness in endemic countries of sub-Saharan Africa. And this has remained the case for decades, despite the evidenced interventions such as intermittent preventive treatment of malaria in pregnancy, with copious recommendations for how this should be done. In this study, what we sought to do was to understand the barriers and the enablers of ITPT use in study communities and facilities in Western Nigeria. And what became very clear, particularly there are many other findings, but I'm just restricting our findings to the theme of this year's conference, what we found was a low awareness of ITPT among women and care providers, which actually surprisingly appeared to be influenced by the attitudes of antenatal care providers with regards to providing respectful care. Next slide, please. What we found was that women want care that respects and acknowledges them as well as treats them with dignity. In one of the focus group sessions with pregnant moms who attended a traditional birth attendant facility, so the setting in Nigeria is that antenatal care is provided both within the facility setting, the various facility settings and or standard hospitals, either in the government or private sector, or by traditional birth facilities, some of which are privately owned. And we conducted focus group discussions across all of those different facilities and communities. One of the pregnant women said the quote that I show on the upper half of the slide. And what that said, next, please go back to the previous slide. So, oh, what's going on? Could you please go back to the previous slide that I was talking about? Thank you, sir. So one of the women said, one can say mommy, and that's what they call the traditional birth attendant. So the mother who's pregnant says, mommy, this is what is happening to me, and they take care of you well here. That's what the mothers felt. They sit you down, that is the traditional birth attendants, and they explain things to you. In contrast, the nurses that's in the public hospitals are harsh. Here, they play with us, in the traditional birth attendance facility. They play with us, they sing with us, they talk and advise us on what to do. And it's not only during clinic day that you can ask questions here at the TBA facility. In contrast, the nurses don't have time. Sometimes you go and they shout at you like you're a child. They talk carelessly all the time. You're waiting for them, the nurses, and they're playing with their phones or talking. I'm sure this is a minority rather than a majority, but that's just the perception of what the pregnant moms who attend antenatal facilities say. And when we interviewed the caregivers, there was a recurring theme with regards to respectful care. And another caregiver who was observing the interactions between the moms and the healthcare providers in the hospital said they shout at them. That one is common in most hospitals. They'll just shout, sit down somewhere, and it's not supposed to be so. They don't take time to explain things. I went with her one time, and that's this caregiver, and I saw it myself. The nurse was shouting at them. A small girl, the nurse, the women cannot ask questions or do anything. And it's their behavior that is causing the women not to come. So clearly there was a real subscription to traditional birth attendant facilities. And it was very clear that dignity and respect informed the choices by the women for where they actually have antenatal care. But actually what was really instructive was that the most TBAs were really unable to provide information on ITPT and did not have the medication to administer the WHO recommended directly observed treatment, meaning that the need for respectful care led women to facilities and providers who were nice, very nice, but did not actually have the wherewithal to provide appropriate and effective care. And one of the emerging conclusions from this study was a need to sensitize healthcare professionals regarding respectful, empathic, and dignified care to improve uptake of evidenced effective malaria in pregnancy interventions in that particular context. Next slide, please. Similarly, our current work on facility KMC in both Bangladesh and South Africa has been paused thanks to the pandemic, but it's been exploring barriers and enablers of KMC from the perspective of the women, and it is hoped to include a co-production of simple and culturally appropriate improvements based on an understanding of women's expectations and challenges. Across a range of all the other work strands which we have not discussed today, we have developed a theory of change to inform the next phase of the co-development of interventions for women, healthcare professionals, and we've already had a number of engagements with the policy planners to inform service delivery to mitigate preterm births. Next slide. So it may be slightly premature, but I just want to acknowledge the group. We don't have a photograph that has everyone there, but this is just available on our website for more information regarding the work that we do. And we'd like to acknowledge the funding from the NIHR, the Academy of Sciences that provided us a networking grant, and the GCRF funding from Research England. So we'll now move on to take two very short videos from two of my colleagues. Dr. Bronwen Gillespie is an anthropologist on Prime who will present on our work in Gauteng, South Africa. And this will be followed by Ms. Shimona Salam's video that will present our work, who's also a public health social scientist here in Sheffield, who will outline a few of our findings from rural Bangladesh. So the first video, please.
Hello, my name is Bronwen, and I would like to talk about our social science work already introduced by Professor Anamba. In South Africa, we've been focusing on adolescent experiences of contraception, pregnancy, and motherhood in disadvantaged neighborhoods near Pretoria. So we feel this topic, respectful care, is relevant for adolescents seeking sexual and reproductive health. It has important implications for maternal and neonatal health outcomes. Now, in South Africa, adolescent-friendly policy exists, including free access to contraception without parental permission, fast-track lines for adolescents, and training for health professionals, amongst others. However, implementation is very uneven and remains low in some clinics. So perceptions of adolescents, while many do use clinic services, others are dissuaded by the circulation of negative rumors. We can see one girl's account of her experience here. And both in the literature and in our fieldwork, we found that verbal abuse and and lack of privacy were reported by adolescents as important limitations in their access to contraception. They felt the care they received was improved once their baby was actually born. They were then treated more as an adult. This means that many sexually active girls avoid using clinics, resulting in high numbers of unwanted pregnancies in schoolgirls, and often implies late presentation to ANC, which we already know can lead to further complications, including preterm birth. So experiences of healthcare professionals. Staff report operational challenges, mainly a lack of human resources. The nurse quoted here spoke about overburdened staff and explained how letting teens jump to the front of the queue caused conflict with pregnant women and others who'd been waiting for hours to be seen at the clinic. So health staff did actually also speak about the positive impact of training programs, especially in terms of challenging intergenerational authority and taboos on adolescent sexuality. So as suggested in the next quote here, nurses have to avoid thinking of themselves as mothers or as elders, traditionally authoritarian, and instead become allies of teens. So we could see the risk of asking nurses to promote sexual and reproductive health without a respectful approach. For example, a case where one nurse refused to remove a girl's implant and the girl ended up cutting it out herself. So lastly, towards implementation, our plans for the future, respectful care will be a central element in our plans to work with both education and health sectors and in community engagement. So why respectful care? Well, in clinics, for example, there'll be promotion of training for all clinic staff, interpersonal skills, respectful communication, and this includes the notion of adolescents as having the right to make their own decisions and being treated as such. This would be for all staff, including receptionists, who can serve as a barrier sometimes. This also would be to facilitate implementation of measures to improve privacy and specialized care, such as dedicated adolescent champions, adolescent-only rooms and lines, for all health concerns. Now, this means that adolescents wouldn't feel singled out and observed by neighbors and relatives using the clinic, and can build up trusting relationships with staff. In terms of community engagement, this would be in order to help normalize the idea of contraception for teens. This would help build support for nurses and teachers and remove some of the secrecy that discourage adolescents from seeking help. Just lastly, let me please thank the whole PRIME team, Professor Anamba, and also in South Africa, Dr. Priya Samapalai, and our funders, of course, and please urge you to get in touch. If you have further questions, I would love to discuss this further.
Thank you, Professor Anumba, and thank you, Tina. Unfortunately, we have just exceeded the time for the session, but these were two, packed, very powerful presentations, which really went on to highlight some of the key principles of implementation science and research that we've talked about all day in this conference. And very importantly, thank you for the rich information you provided about what the NIHR, funder and the research themes are about what the clinical group is, and a lot of the studies which you have talked about in various contexts. What really stood out for me was the way you were able to co-create research with the various partners on the ground, right from the planning stage, and also thinking about evaluation right from the planning stage. So I cannot emphasize enough why this is so important. Research prioritization, early engagement with stakeholders, community engagement and involvement with common threads across both presentations, and really contextualizing, what research took place, and they built in how this will be sustainable and how research will be taken up in all of these settings. Now we've run out of time, we have to stop, but all the content, the second video from Professor Nuba's group is embedded in his presentation and will be available online through the web for the next year. Now, the very interesting questions all, in the app that have come through, and I'll just, plead with our presenters, the panel, to respond to each one of those ones, because for every answer you give, over 1,000 people, would benefit from those questions, and they're very relevant questions. So I just want to conclude by thanking our panel, Professor Anumba in Sheffield, Professor Tina Lavender and Dr. Tracy Mills. So I want to say thank you to those sitting with me here and also use this opportunity to welcome them to LSTM. Thank you. So.